Thanks everyone. So we've heard of the major elements of our system, haven't we? A lovely introduction in detail from our Health Minister, a detailed discussion with our CEOs about the complexities of our public hospital system, and then an amazing presentation of the significant investment in infrastructure. But each of our speakers so far have indicated the importance of primary health networks and our GP and community-based care. So I think we'll start this session. Welcome to our team. We've had a bit of a preemptive discussion about what's most important, but we might start with a commentary from each of you about our workforce challenges, if that's okay. So we might start with you, Keith.
Oh, thanks, Annemarie. It's probably the biggest burning platform for primary healthcare in Greater Western Sydney. A study was released only last week by the government which said that New South Wales now has a shortage on relative unmet need, has a shortage of 460 GPs. I think that's an underestimate. Within 4 years, that will be 1,000 GPs. And given that Greater Western Sydney is the biggest growth corridor in the country, we're sharing the lion's share of that burden in terms of shortfall. In southwestern Sydney, in 18 months, we had 33 practices closed in the last 18 months. It's the centrepiece of primary healthcare, but it's suffered a lot of shortfall in investment, and there's a number of strategies that we think could turn that around. But I'll throw the other guys first.
Well, we'll come back to the strategies in a moment, yeah.
So certainly I completely agree with Keith, and in our area, and we look after the Blue Mountains and Hawkesbury and Lithgow as well as Penrith, we have, just in the Blue Mountains alone, 20% of our GPs are over the age of 65 years of age. There's poor succession of that. We have workforce policies that are currently under review, but they're outdated, and they're not thinking about the needs of future workforce planning that's required. And so that makes it really difficult, particularly on what Keith was saying about this area that is in significant growth, and yet we can't apply any of those workforce incentives to these growth areas until we're at GP shortage, and it makes it really challenging.
So you've got to get the problem elevated before the solution, yeah. Andrew?
Yeah, thanks, Annemarie. I think being the person on the panel who's recently come out of the acute sector into the primary sector, I certainly do want to acknowledge the workforce demands in the acute sector. But being 5 minutes in the primary health sector, I want to just comment on how hard the GPs are working in Western Sydney, which is my patch. But there is an increased demand and supply issue there, but it's wider than general practitioners. It's practice nurses and it's allied health practitioners, and it's really the funding model does not lend itself to having a sustainable workforce in the practice areas. And so what's been really welcomed is the review of the workforce incentive programme to really have a sustainable workforce beyond GPs and allow GPs to practice at level and let the other practitioners do patient care that does not need a doctor to do that.
Okay. So solutions, let's go around again. You've got some ideas.
How long have we got?
Yeah.
So I think there needs to be, and there is in the Strengthening Medicare Task Force, some change in terms of trying to positively invest in primary health care, and that needs to not only stay the course but probably accelerate. Some of what we've collectively have put to Minister Butler is that there needs to be consideration around using the ABS CFA indices for disadvantage in things like incentives for general practice and primary health care more broadly. And a study came out, the AIHW study came out only this week, and they've actually developed a metric around that, like access relative to need, and guess what? Greater Western Sydney is the hotspot for it's actually a low score is bad, and Greater Western Sydney scores badly. I think Sonia pointed out that Fairfield is the poorest LGA in New South Wales, poorer than remote areas like Wilcannia. Yeah. So if you had an indices that could recognise CFA, so that attracted investment, and so doing something about the inverse care law, because at the moment the way primary care is structured, people go where there's the most affordability to pay, not where there's the most need. And the workforce should be attracted to where there's need. Then I think the supply chain in terms of becoming a GP, for example, that's choked off at multiple points. So if there was a program a few years ago, and I worked, ran practices that used it. It was called PG Triple P, and it was having rotations for junior medical officers into general practice. That should be, reintroduced, because there's 3-year gap where they're just lost to primary healthcare, those junior medicals. We strongly want to encourage. So at the moment, there's been trials in rural areas about single employment models for GP registrars. We would like to see that in outer metro Sydney, a single employer model for GP registrars. So they do their training and they become embedded in the culture of the practices over those 2 to 3 years of becoming a registrar. And then certainly there's a role to play for the universities in enhancing students' exposure to general practice in training. I think so. There's a key choke points that need to be addressed in that supply chain.
That's a comprehensive answer, isn't it, Karen? Do you have...
So probably in addition to that, one of the things that we certainly have been advocating really strongly for is around the classification of the modified Monash model. And so in our region, we have, most of our region is what would be classified as MMM1, but we do have areas that are classified at MMM2 and 3. But one of the biggest challenges we have is the Upper Blue Mountains. And if any of you are quite aware of the Upper Blue Mountains, when you're thinking about Katoomba, it doesn't have access to resources. It doesn't have the support that's there. It's very much a regional town, and yet it's classified as MMM1, which means that from a workforce perspective, they're actually competing with Parramatta. It's competing with Blacktown, it's competing with Sydney, and doesn't have an opportunity to have other workforce incentives. So what we'd really like to see, and we've been advocating for as well, is that opportunities to look at the nuances within that. It's not a metropolitan. So what happens in those outer metropolitan areas, so that can actually be some form of exemption for those things.
So we're seeing a broad range of possible solutions. And you proposed some already. Have you got more?
Probably two. I'll just add Annemarie. It's working with you guys in the universities in all disciplines to get student placements out into primary care. And even if we don't keep those in the workforce, they'll have an appreciation of the health needs, the information needs for the practitioners, particularly when doing the likes of discharge summaries. But it's also growing awareness in the community. So I'm going to give a plug for our Citizens Assembly in Western Sydney now, some who I know are here today. And a couple of the priority areas there are to grow an informed community who might want to help then deliver or move into health-related practice and start to grow our future workforce from high school right through.
Thank you. Look, I might just make a comment because prior to my current role at the University of Sydney, I was the Dean of Medicine at Western Sydney University, and at the time that we started the school, you couldn't get after 10 o'clock at night GP appointment west of Ingleburn, and there's a whole lot of the population lives south and west of there. And that program was set up with a very specific agenda about integrating general practice and local general practice into the course. And I'm just preparing some data at the moment with the team from that university about the success of GP conversion out of those graduates. But the problem, as I see it, is, as you've indicated, that there's absolute cap on medical student places, and without a growth strategy. And I know Peter and I have agonised about this for years, but an incremental growth strategy which would make a whole lot more sense than this sort of hard cap that then goes on for a decade or a decade and a half, and then wondering why we've got a problem with the gap. And also reflect the fact that we do all of that work to try and integrate general practice into the training program, and then have 3 years of sitting around in hospital rotations being told that this is where the real medicine is. And so we've got a structural problem that was, partly solved. So we can turn some of this around, but like everything, it costs money. I think part of this group should not just focus on medicine, of course, but lobbying for that federal-state relationship that allows us to grow our training places in the right places. You've kind of touched on those, so thank you. I think one of the things that might make all of this work better, and all three of you have raised this with me, is around integration between the acute system and the public system. So moving away from workforce but into ways of working. Do you want to each comment about integration, interoperability, consent, and how you think those things might actually elevate your work? Yeah.
Thanks, Annemarie. So I actually think New South Wales is a step ahead of some of the other states, but in the National Health Reform Agreement, there's a couple of recommendations come out of the midterm review around embedding systematically around integration, particularly primary health care and the acute care systems. And as I say, New South Wales, there is a statewide approach. There's a joint statement and with some broad commitments, and it's around now seeing those commitments turn into action. And you know, I'm happy to say in South West Sydney we do have a collaboration agreement with some joint scope of works, and happy to rattle those off. But there was actually a commitment to getting job tasks done, you know, task strategies done. So that's encouraging, and I guess the review is about trying to see that systematically embedded across Australia, and New South Wales, as I say, I think leads the way according to the Commonwealth. So that's good news. The happy to bang on about interoperability if you like. Yeah. So there's a number of strategies around, you know, digital health and improving people's access through digital health or virtual care. But the big game changer, which at the national level they're trying to drive through a national blueprint, but we are testing in South West Sydney, is around the clinical information exchange in real time between clinicians for primary purpose, i.e. patient care. And we're testing that live in practices now, so the technology exists. The issue is we now need to try and push a change in legislation. So because the only system that allows opt-out currently is the My Health Record. We want to try and test that between the LHD and ourselves as a use case between acute care and primary care to get an opt-out trial, if you like, a test bubble, so that we can actually get this system scaled. So what it would mean is that within seconds, you get the information between records on the desktop, single sign-on. And but it all hinges on patient consent.
If we can do it for the ambulance, can we do it in general practice as well? Karen, do you want to comment about?
So I completely agree that that single patient record, it would be a game changer. And we certainly hear from GPs that they don't know where their patient is within their journey across the health system. And so that would change the way that happens. And in integrating those systems, we're then actually integrating it as a one health system. And that's one of our challenges at the moment, because we are seen as separate systems, we're separately funded, and it makes it really challenging for patients and also for clinicians. And so looking at ways of doing that and having an enabler from a digital perspective is really important. We, very similarly to South West Sydney, have a joint governance with the LHD for integrated care, and that has been a really strong vehicle. It has the joint board commitment, and it's a strong vehicle for any work that we're doing in relation to integrated care, and has certainly been of assistance in any of our joint work that we've been able to achieve across the region.
So the solutions are in front of us a little bit, aren't they? Yeah. Andrew?
Yeah, I agree with what my colleagues have said, but also I would add a couple of things, and that's there is an opportunity to strengthen the relationship between primary and acute settings. We heard a list of things this morning from Minister Park about ED demand, and if we really think about right care in the right place and really partner stronger with the acute setting, and there's effort needed on both sides for that. But from a connectivity perspective, we do have a once-in-a-generation opportunity coming up with a single digital patient record, which honestly isn't. It's a single digital hospital record, and we really need to think about connectivity back into GP and primary care on how we can really have that single digital patient record that's really owned by the patient, not by a system.
Yeah, I couldn't agree more. There's a fear, isn't it, that is an add-on rather than is actually being a fundamental building block of the development of an electronic record. We might move to our questions now. I mean, each of you have mentioned the interdisciplinary approach. And there are some questions here about nurse and nurse practitioners working to their full scope of practice can significantly improve health outcomes. How can we leverage this? How do we create a better approach to workforce to support a whole of team approach to primary care? We might work backwards this time, Keith. Andrew, do you want to start?
Yeah, I think that there's a great role for nurse practitioners in the GP in the GP setting, but it's just not like flicking a switch. There's got to be a change mechanism. It's like when Emma would have been talking about building hospitals before. You don't just get the bricks and mortar. There's a whole change process that's got to be done, and it's making sure that firstly, is the current scope of practice for nurse practitioners fit for purpose? Does that need review? And really thinking then about the value add that gives to the patient, particularly becoming patient-centred, and then allowing capacity for GPs to do the more chronic care, the more complex, and the doctor-type work in addition to that.
Do you think the universities have got the right settings around providing those elements of that you've just mentioned?
I think probably from a curriculum perspective, but I'll come back to the placement perspective. It's linking that theory to practice and getting more into the care settings to drive an appetite to work in that area.
It struck me listening to the Minister's list, particularly around things like Health Direct. Where is the point that we're actually training in those environments to make them work optimally? That's something I will take away from this morning. Your comment about other practitioners?
So there is at the moment the scope of practice review that's being undertaken right now. It's in its third phase, and some of the findings already indicating the need for change in regulation. And I think it's much broader than just nurse practitioners and nurses. We need to be looking at allied health professionals and their role and how they can also take pressure away from our acute settings, but also from general practice as well. So we're working better as a primary healthcare as a whole, which sits within the strengthening Medicare changes, and the reform that we're undertaking at the moment, and looking at how multidisciplinary team care can actually be enabled through changing of that regulation. Because at the moment, these practitioners, nurses can't actually bill within general practice unless there's a GP there. It's very much tied to GP, and so there's a lot of reform that's required in relation to that.
Some structural barriers, aren't there, Keith?
Yeah, probably a segue to what Kate's saying is that the big challenge in primary healthcare is we're almost entirely relying on private practice, which are small and medium businesses trying to get through, and there's limited incentive from the public end in terms of practice models for allied health and nurse practitioners and the like outside of out-of-pocket and private health insurance. And so if we want to get a public good out of these expanded scope for these other providers, including pharmacy and nurse practitioners and physios and the like, then there needs to be some public investment in incentivising that. And as I say, the MBS items currently heavily incentivise the general practice as opposed to the others. So there is a move on around rationalising the MBS and increasing, blended payments and packaged payments around chronic disease, so you could get team-based care in the practice. Care needs to be taken that still incentivises, not just a break-even proposition, needs to invest in that model. And also, you don't need everyone under the one roof. It's not necessarily co-location, it's networks. It's the team-based care of networks of providers. So I agree with Kate, there's a lot of work to be done. There are positive signs of that developing. And probably the warning, I was got a negative as well. The flip side of the scope of practice review, it can't be used as just a policy substitution for general practice. It's got to be addition to.
Yeah, and value add. And you mentioned before, maybe the audience isn't aware, but as a trainee in this environment, because of the nature of private practice, junior clinicians don't get the benefits of things like maternity leave or other provisions of leave and conference attendance, and therefore doesn't seem as attractive an environment. And there are some models, particularly in New South Wales, that are looking at the single employer model, which would actually allow some of those benefits to come forward. There's some questions here while we're on this notion of the interdisciplinarity around mental health. It's a significant health determinant, a priority area, but it's not been mentioned very much so far, although we did see some of the infrastructure around particularly child and adolescent mental health, which I hadn't known about in that presentation from Emma. What is health doing to meet the complex mental health needs of residents within your environments? We'll come back to you, Keith.
So a large part of the work that PHN's commission is to mental health, it would literally be half our turnover per annum in terms of commissioning mental health services, and it's what we'd call a step care approach from, if you like, this sounds cruel, but the worried well through to the medium complex, and then having escalation pathways into the acute care system. I would say that there's a lot of investment in that, and again, it's investment in private practice so that people have access to care that they otherwise couldn't afford. So it's that public mobilisation of private practice, and it does work well. It's hard to measure the impact, and we are getting to the point where a number of our providers are at saturation points, so they're actually closing their books periodically, and so it's finding those providers that are of a suitable quality to commission is the challenge in Western Sydney, again because of the growth, the high relative need, and attracting providers.
So I'm going to keep you with the mic for a moment because there's a couple of other very similar questions to that about, given the cost of living crisis and the push to mental health needs that comes out of that, what is happening today to make access in Western Sydney easier to the general practice and mental health support that patients might need?
Well, I guess that's the whole reason services are commissioned.
Yep.
And you know, the review of the better access model was because it wasn't necessarily giving access to the most disadvantaged people. So it's trying to get minimise or reduce out-of-pocket expense for them, and it's also trying to get that, as I say, integration with general practice, because access to these, you can have a preliminary self-referral or referral, but you need to have ultimately a mental health care plan with your general practitioner. And so it's trying to get that wraparound care is how the models are designed.
Terrific. So thank you. And Karen, your response to both mental health and the cost of living pressures and affordability in Western Sydney?
So firstly, mental health, just to further add to Keith, I think one of the strengths is that integration across. That's something that's really important, is making sure that we're working really closely with the acute mental health services as well, and so integrating across with and working in partnership with our LHDs is critical for that. In relation to cost of living, it's really challenging. We're hearing all the time that it's really hard for people to be able to access health services, and there's an opportunity cost there that we know gets applied because they can't afford to actually access these services. And that's where the services that we fund certainly have a role to play in that. What we do know is that in our region, so in Nepean Blue Mountains, we still have a high percentage of bulk billing practices, so 83% of our 83% of bulk billing actually is within our region, and certainly Southwest Sydney and Western Sydney are sitting a little bit higher than us again, and so that's at a state average it's 78%. So we are still sitting a bit higher there, but we do know that that is a challenge, and health literacy as well comes into play with that too, for people being able to navigate and understand the health system and the socio-economic area that we live in, and the challenges that we have around multicultural health as well has an impact on people being able to appropriately access services, know where to go, and have that health literacy to be able to do so.
Thank you. Andrew?
From a mental health perspective, there's only last Friday there were 3 more Medicare mental health urgent care centres, announced 2 in the patch that we're talking about here today at Campbelltown and at Blacktown. So that gives consumers a direct point of contact, but also GPs somewhere to refer to. But also we've got to think about the concept of social prescribing. And only a few weeks ago, several of us in this room had the pleasure have been at a new safe space at Wentworthville, which has been coordinated by our Tamil community, really to think about and support people with mental health issues and potentially suicidal ideations where mental health is a stigma in some cultures. And then just thinking about the cost of living as well as for health, we've just got to think in our patch, the difference in life expectancy between Bidwell and Cherrybrook, it's 69 years at Bidwell and 89 years at Cherrybrook. And that's because we're in an area where we know there's a very high prevalence of diabetes and pre-diabetes, but we're also in an area which we class as a food drought. And if you look, there's a line now called the Red Rooster line, and you can see where the Red Roosters are in Western Sydney, and there's none east of that line. And so it's convenience, it's life choices, and so we've got an opportunity to balance that cost of living with better health information in our community.
It's a headline fact, isn't it, that we should all know and think about. We've got time probably for one more question. I'm going to tie two things together. There's a question here. There's a federal election in 12 months, and what policy changes do you want? But I'd also like to frame that, if you don't mind, because each of you raised it with me, within the context of the Strengthening Medicare Review and the primacy within that review of the role of our consumers and assemblies in helping us make our decisions. So we'll start with you, Keith.
I'm encouraged at a high level by the Strengthening Medicare initiatives, and I'd like to see it stay the course, provided that it's genuinely about investing and strengthening the sector and integrating it with aged care and acute care. It doesn't become a political football. So I think if we could stay the course, have bipartisan support for the embedding those strategies, and because they are around, and you know we hear now about the patient registration, the voluntary patient registration. That's around building wraparound care and continuity of care, and that's too long we've incentivised rapid access, but not continuity. And the evidence shows if you want to keep someone out of hospital, you have continuity care with the same practice.
Fantastic. Karen?
So very similarly, I'm really excited about the 10-year primary healthcare plan. I think there are great opportunities there for it to come to fruition, but there's a lot of work. There's a lot of reform considerations and reviews that are currently happening which will inform that. And if we can have some positive outcomes out of those reviews, and those reviews then are implemented to support the change in primary care, then I think we've got some great opportunities coming forward. And I think it's an exciting space. It's the biggest reform that primary care has seen in Australia, and it really can be quite exciting, but there's a lot of work to do.
Fantastic. Andrew?
Yeah, and I echo with what my colleagues have said, but also there's got to be an awareness for our communities as well. So there's got to be a what's in it for me, for our people seeking treatment and care and ongoing care, particularly for chronic illnesses with our GPs, and the care and the services that are available once Strengthening Medicare really kicks off.
Fantastic. Well, I think you can see that our primary care and our general practice thinking, strategy and operations are in great hands. There are a whole lot of questions, so particularly questions about university and access. I'm happy for you to come and talk to me during the break. I'll be here all day, and I'm sure our colleagues will be happy to take your questions, but we need to finish the session there. Thank you once again for your great ideas, and keep going. So thanks so much.